correctly now?
Yes.
Yes, everybody is good. Perfect. Let me know if there is any technical issue during the talk. I will be glad to fix it. So thanks a lot, Aisha, for the introduction. So I will start with the talk. As you said, I'm working in reproductive genetics, and I will be glad to present some of the main aspects of genetic counseling for fertility and assisted reproduction techniques. And for sure, I don't know exactly how it works in Pakistan. So the point is really to, discuss about what we know and how it's working most in North America. And I will be super glad to discuss with the local doctors and professional working in Pakistan at the end of the talk. So all of what I'm saying right now may not apply fully to the situation in Pakistan, but I'm sure it's going to be a very interesting discussion for that. I will start to discuss a little the genetics of the infertility, but first, this is some of the objectives of the discussion today. I will go directly to my first slide. And Aisha already discussed a little about it. I just wanted to add that recently we had like a World Health Organization report that really enhanced again like the importance of the infertility as health issues all around the world. And it's actually now up to 17.5% of the adult mondial population at reproductive age that are concerned with the infertility issue. So approximately 1 over 6 couple will experience a problem conceiving. The exact definition of infertility is generally a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. So this is like the general definition. And actually the recommendation by the World Health Organization, this is applying to every country in the world. It's after 6 months of trying to conceive, if a woman is after 35 years old, she should be referred for an infertility workup to evaluate like the problematics of the couples. For younger women before 35, most of the time they say that we have to wait 1 year, and the definition of infertility is generally after 1 year of attempt. But because after 35, the fertility can really decline rapidly, we don't want to wait too much, and a referral after 6 months would be indicated. We know that infertility is not only associated, of course, for female issues, and I will discuss that later, but we know that the female age is unfortunately one of the main parameters, and that there is a significant decrease of the fertility potential associated with the increase of the female age. And as we know, there is kind of an increase of like a delay of the time of childbearing, especially in North America, where like the couples start later to have kids, and this is one of the main issues that make more difficult for the couple to conceive. And we know that even if all the world is concerned by the infertility in all the country, in the last World Health Organization report, they really mentioned that the financial burden for the developing country is, of course, much more significant because there is a lot less assistance and accessibilities for the services. If we talk about etiologies, we know that infertility is very complex and very multifactorial. There is not like 2 cases that are the same. It could be associated with hormonal disbalance. It could be immunological cause, infection. It could be also psychological. We sometimes have some gonadotoxicity after like cancer treatment. There is a lot of reasons that can lead to a problem to conceive. Today, we're going to focus on the genetic causes. And from all genetic causes, we know that approximately 10% of the genetic cause of infertile women have genetic cause, and 15% of infertile male have a genetic cause. So it's still a significant proportion of patients that we can help with genetic workup to understand what is the etiology. And when we talk about genetic, I like always to detail a little more, because for some people, they say, oh, I had a genetic test, it was normal, so it's not genetic. But as you may know, it's much more complicated than that. There is a lot of different type of analysis and type of genetic issues. And here are examples of type of genetic cause, like you can have chromosomal abnormalities. So it can be aneuploidy, so like extra chromosome or missing chromosomes. It could be copy number variant. So those are like the microdeletion. and microduplication, which are much smaller, like imbalance in the chromosomal contents. You can also have monogenic disorders. Monogenic disorders are genetic conditions with like single genes or small like spelling mistake in the gene, like mutations. And you can have all the multifactorial condition with a lot of involvement of genetic, but also environmental and random factors, and also some epigenetic disorders. So epigenetic, it's not like mutation in the DNA, but like in the regulation and expression of the DNA. So this is just to show you how complex it can be when we talk about genetic in general, and in particular infertility. So the point of today is to give you like not the details of all possible genetic causes for infertility, but at least what is done routinely in a fertility clinic to rule out the main genetic cause for infertility problem. And this we talk already, but I think it's really important like to mention it. Most of the time, we think that the infertility is more like a female problem because the female is supposed to carry the kids. So we think, oh, if it's not working, it should be associated with a female issue. And as you can see it very clearly in these graphics, there is the fair share of the burden of the infertility in the male, in the female, and sometimes in both, or maybe unknown, depending of like the situation. We are not always able to identify the cause. So definitely, even if in general we think that the problem would come from the female part, a lot of the time, like we see that if at the end it could be also the male infertility, which is involved like in the problematic. So this is really important to keep in mind. When we talk about fertility treatment, some people, they always think about, oh, fertility treatment is IVF, like in vitro fecundation, but fertilization, sorry, I put it in French. But there is a lot of different treatment actually that exist and that are offered in fertility clinics. It could be hormonal therapy, insemination. In some situation where we have to do testicular extraction, we can have the in vitro fertilization, but there is a lot of options that can be offered, like also the gamete donors. So all of that, it's going to depend of course, what is the cause of the infertility and of the evaluation that the couple will have when it's going to be seen in a fertility clinic. And I'm going to discuss now like the main assessment that are done for male and female in fertility clinic to determine what are the cause of the problematics. If we talk about the female assessment for fertility issues, so we're going to discuss what is the ovarian reserve. The ovarian reserve, as you may know, as females, when we are born as embryos, we already have all the pool of our gametes, like our sex cells, and this content of oocytes is going to decrease during our life after puberty with each ovulation. So we know that this ovarian reserve, this pool, is going to decrease with the age of the woman for sure. And this ovarian reserve assessment should be actually offered to any woman that is wondering about her fertility. The specific indication here is for sure every woman that wants to go through an IVF treatment, every woman after 35 or before 35 with specific risk factors that are here. But globally, any woman that questions her fertility and want to kind of plan for her reproductive option could decide to ask for ovarian reserve assessment to know, for example, if it's worth it to have fertility preservation, or if there is any reason for them like to change like the plan for the reproductive timing. So this is important. And the way to evaluate this ovarian reserve is actually through two modalities. The main ones are the antral follicle count that is done through an ultrasound, a transvaginal ultrasound to see the count of the follicles. And another one is made through like a blood test. So a blood test looking at specific reproductive hormones, the main that we use being the anti-Mullerian hormones like the AMH. So like a combination of AMH and antral follicle count is most of the time good to have an idea of like the fertility potential of a female, but sometimes you need more information. And sometimes even with a good like antral follicle count and good AMH, you can still have a bad response to an hormonal stimulation after like a cycle of IVF, for example. So there is other parameters, of course, that are really important to evaluate all of that. Important to know is when there is like AMH and follicle count that are below certain threshold, we can talk about a premature ovarian failure. So premature ovarian insufficiency or premature ovarian failure, it's a very, very heterogeneous condition. Plenty of different causes can be involved. And we think it's 1% of women of reproductive age that could have like a problem associated with that. The clinical features is like a poor stock of like ovocyte, like causing amenorrhea or oligomenorrhea. And you can also have association with increased risk for osteoporosis and cardiovascular disease. This condition, as I said, is very heterogeneous, and it could be acquired after, like, for example, like a gonadotoxic treatment for cancer or any other like surgeries, but it can also be metabolic, infectious, associated with autoimmune disease. Now we're going to discuss more about the part when it's genetic. Actually, a significant proportion of female with premature ovarian failure are going to display some genetic problematics that we can identify through testing. So it could be either monogenic or chromosomal anomaly, and I will discuss now like the main cause that we can identify. One of the main causes that we identify frequently in fertility clinic associated with the premature ovarian failure, it's actually Turner syndrome, which is also named like the monosomy X, 45X. And this is actually a syndrome that is very, very variable in the expressivity. Some females are going to have some significant features from the prenatal period to all their life, with possible like implication of cardiac malformation, learning difficulties. But some women are going to be absolutely asymptomatic all their life, and the only features they will develop from this syndrome is the premature ovarian failure. It happened a little more in the mosaic form of the condition, and it's one of the syndromes that we can identify quite frequently in infertility clinic, and those women were absolutely not aware of this syndrome before most of the time. The other one that is also very frequent is the Fragile X syndrome. If you already heard about this syndrome, you probably know that it's involved with intellectual disability and autism spectrum like disorder, increased risk, mainly for male, but also for female, but with milder symptoms. And actually, some women can have a pre-mutation for the Fragile X syndrome. It's not like the full mutation. So those women do not have any significant issue. They don't have any intellectual disability, but they manifest the syndrome with a premature ovarian failure. And this is particularly important to detect because, yes, we can explain why the ovarian reserve can be, very low, even for young women, but also because those women are very high risk to have kids affected with a severe genetic condition affecting like the intellectual, the potential of the kids. So this is really important. And we identify actually premutation in up to 16% of female with premature ovarian failure. So it's not something that we can let go. I don't detail, but there is other condition that can be associated with premature ovarian failure. But I just presented like the main ones, and I presented the ones that are not syndromic because there is other ones that are more syndromic, but those ones can be tricky because you can have absolutely no other symptoms. So it can be quite a surprise for the patients. Because of this condition that can be really important for the care and the coordination for the reproduction like option for the patient, the genetic investigation we offered for female infertility consists with like a karyotype that is done to rule out like Turner syndrome and other X chromosome rearrangement that can be present. And we always offer also like a Fragile X analysis to make sure there is no premutation. For specific cases where we feel that there is something else to test, most of the time it's when we see that, for example, the couple, they tried like for an IVF cycle, and we see that it seems to have like an oocyte maturation defect with like an early development arrest of the embryos. We sometimes go further and offer CGH analysis and a molecular panel, but it's really case by case. It's not done routinely. But the karyotype and the Fragile X analysis are done routinely with all women with premature ovarian failure. Now, if we talk about the male factor, as you may know, the spermogram is one of the most important assessments for male fertility. It's looking at 4 different parameters, all of them very important. the volume, the mobility, the morphology, and the concentration. And the one that we're going to discuss a little more is when we have a problem with the volume, with the concentration. When we have a low concentration, we call it like oligospermia or severe oligospermia, when there is not a lot of spermatozoid in the sperm, and we call it azoospermia when there is absolutely no spermatozoid identified in the sperm. All of that, of course, can happen even if there is a normal ejaculation and a normal volume of sperm. So it's a really important thing to assess when there is a fertility issue in a couple. And here are the main genetic cause for oligo or azoospermia. You may have heard about it, but one main cause, genetic cause of obstructive azoospermia is associated actually to cystic fibrosis. So when we talk about obstructive or non-obstructive azoospermia or oligospermia, it depends of if we think like an obstruction is the cause of the problem, as you can imagine. So most of the time it's with the palpation, like the urologist or the fertility doctor can feel if they find like what we call like the vas deferens, which is a canal that is supposed to bring like the spermatozoid up to like for the ejaculation. And if we don't with the palpation, we cannot identify it, it seems to be obstructive, then we're going to offer the testing for the cystic fibrosis mutation. The male that display these features, most of the time it's male, as we already discussed for the female genetic factors, that are asymptomatic. They do not display any of the classic symptoms of cystic fibrosis, but still they carry some type of specific like mild mutation that are associated with the infertility, so like the absence of the canal. In those men, normal the testicular development is here, so they have normal like external sexual characters, they have normal spermatogenesis, but the spermatozoid cannot make it to the end. So in those male, once we identify this, they can have access to testicular extraction to get the spermatozoid and to use it with an IVF with ICSI being like the intracytoplasmic injection of sperm. And of course, in this setting, as you can imagine, because cystic fibrosis is an autosomal recessive genetic condition, it means that if the female partner is carrier for cystic fibrosis, there is a risk to have a kid with a severe classic form of cystic fibrosis. So it's very important to offer like the genetic screening for the female partner. Now, if we talk about the non-obstructive microdeletions, the non-obstructive cause for azoospermia and oligospermia, those are the microdeletions of Y chromosomes that are one of the things we want to rule out. It's quite important. It's up to 15% of all azoospermic male, up to 5% of oligospermic male. So really important to identify those microdeletions does not cause other symptoms. It's really only a problem in the spermatogenesis. So here it's not a problem, it's really a problem of like the fabrication like of the spermatozoids. So this is something that we offer like to all patients with oligospermia when it's non-obstructive. And the other thing is the Klinefelter syndrome, which is a sex chromosome aneuploidy with an extra chromosome X. So you can see it is 47XXY. And this syndrome is actually causing up to 10% of the non-obstructive azoospermia. So also a significant number of patients, male patients, that can be referred to us because of azoospermia, and they have no other symptoms sometimes, and they discover that they carry like these extra chromosomes. For this condition, you may know about it. It's actually quite frequent, and most of the male are not even aware they are a carrier of these extra X chromosomes, but some male can display some hormonal changes, like we call it like hypergonadotrophic hypogonadism, but you can have like some gynecomastia, so some male that can develop like some kind of breasts during puberty. They can have less hairs, they can have some changes, hormonal changes that could be sometimes a reason for them to have an earlier diagnosis, but a large proportion of the men are not aware of this diagnosis before having fertility issue. For those patients, the sperm extraction and IVF is possible, but not for all the case. So in 30 to 50% of the case, they are still able to conceive biologically, but sometimes they need to use a sperm donor, depending if it's possible. Because of those genetic causes, what we offer for a workup for male infertility in genetic would be a karyotype and an analysis of the microdeletion of the Y chromosomes and a cystic fibrosis carrier analysis if it's an obstructive one. In specific situation, case by case, we may offer like some more molecular panels if we see like a specific pattern in the fertilization, but it's not for all the patients. There is a lot of other genetic conditions associated with infertility. I will not detail all of that. I just put some interesting thing here. You can take the time to look at it if you have access to the presentation and the slide. I will go now with another cause of referral infertility clinic and associated with genetic also, which is the recurrent miscarriages. So recurrent miscarriages are defined by 2 or more failed clinical pregnancy, and it's normally excluding the biochemical pregnancies, but also there is case by case like evaluation. Sometimes we can include them if there is a lot and we don't find a cause. And it's supposed to be up to 15% of clinical recognized pregnancy that are recurrent miscarriages. A lot of different etiology exists. In more than half of the time, we don't know what is happening. You can have all these factors here that I mentioned that can be here associated with that. But now we're going to talk about chromosomal anomaly, so extra or missing chromosomes. And it could explain up to 80% of all unexplained miscarriages in women after 35 years old. So it's a very significant cause for recurrent miscarriages. As you may know, the process of those aneuploidy is most of them non-hereditary. So it means that most of the time it's really like a sporadic aneuploidy due to what we call a non-disjunction. So it's just the chromosome, instead of going in the right cells to separate in right cells, they go to chromosome in one cell, no chromosome in the other one. And because of that, we have the imbalance in the chromosomes. And actually, the way we think it's working is like because there is too much extra or missing quantity of chromosome, there is some kind of natural selection from the body to have the spontaneous interruption of the pregnancy. And what is important is to know that the proportion of the actually inherited cause for those miscarriages being like the translocation or in general all the balanced chromosomal rearrangement, it's actually not a lot. It's just like 2 to 5% of the recurrent pregnancy loss couple that really have a hereditary cause. So when we say that the recurrent miscarriages is due to genetic or chromosomes, it's really important to make the difference between the hereditary balanced chromosomal translocation that can be inherited from the male or the female. It can be both, one or the other. The most frequent are the translocation, but sometimes, and most of the time actually, the chromosomal issue is happening at the time of the fertilization, and it's not present on the male, it's not present on the female, and still there is an abnormal chromosome being here. The main factor being, again, the age of the woman, but there is other factor that can be involved as well. So here it was just an example of the few main chromosomal rearrangement that can be associated with recurrent pregnancy loss. For the genetic workup, when we have a recurrent pregnancy loss in couples, for sure, even if it's just like maximum 2, 4, 5%, we still need to make sure there is not a translocation or any other type of balance rearrangement. So that's why we have to offer karyotypes to both parents, not only the female, the male as well, even if it's in the male, even if it's the female having the miscarriage, like the chromosomal content of the male, of course, is really important. Once that is done, if we didn't identify anything with the karyotypes and there is still like recurrent pregnancy happening, one of the tests that is offered somewhere, some places, I don't know if it's the case in Pakistan, you will let me know maybe in the discussion after, but is to try to analyze the fetus, like we call it like product of conception, but to try to analyze like the content of the abortion, if I can say so, to make sure that we don't have an aneuploidy or a chromosomal cause that can explain it. And I will talk about that a little later, but pre-implantation genetic testing for aneuploidy like PGTA combined with IVF could also be an option for those couples. For the product of conception analysis, it's an analysis that we do so on the fetus, like after the miscarriage. The fetus can be taken through like the medical team if the patient have like a curettage, but sometimes if the miscarriage happening at home, it's the patient that have to try to get the tissue, which is quite hard. And the point is to analyze on the cells to make sure there is no aneuploidy on the main chromosomes like 21, 18, 13, X and Y, but also to a CGH, like a microarray, to make sure we do not have any microdeletion, microduplication that can be involved. And this test, it's important for patients. A lot of patients are really relieved when they find the cause. It's quite helping for closure for them if they had a lot of losses. So it could be really important even for the psychological part. But as I said before, it can also help for the planification of the reproductive options, like maybe adding a PGTA to an IVF cycle, if we think that chromosomal issue is the cause of the recurrent miscarriages. So now I will discuss a little more about reproductive assisted techniques and genetic counseling. So it will be mainly a discussion for the context of the gamete donation and a little more about the PGT. I will talk a little about the expanded carrier screening. I think it's a super important topic that is, important for all fields, but in particular in fertility. So you know what is a traditional carrier screening when we focus on the limited number of conditions. So this we based on the person's ethnicity or a specific familial history. So for example, we're going to say, oh, this person, because of the ancestry, the population, we know the higher risk is for hemoglobinopathy. So we going to offer screening for hemoglobinopathy, for example, or, oh, I know that I have a cousin affected with cystic fibrosis, so I will do a test for cystic fibrosis for myself to make sure I'm not carrier. But now the expanded carrier screening, it's a test for a much larger number of conditions. Most of those conditions are recessive, meaning that you need both reproductive partner to be carrier. So you need really the male and female provider of gametes that are carrier for the same genetic condition to have a risk of 25% to have an affected kids. And those big panels, now they are looking at up to 600 and more like genetic condition, regardless the personal background or family history. It's really more like a screening, an expanded screening. And we actually know that everybody's carrier of 5 to 6 silent genetic mutation without knowing it. And some studies showed like up to 4% of couples without any significant family history may be at risk to both carry mutation in the same genetic condition and being so at risk to have unaffected kids for a severe genetic condition. I would say that more and more in North America, I know in the US it's quite like almost automatic. All patients have expanded carrier screening when they are followed in fertility clinic. In Canada, I would say it really depends on the clinic. It's not yet there. It's quite expensive. And the indication, like we kind of, we talk a little more to the patient about those options are here. So for sure, consanguinity is one of the indications because, as you know, when there is a consanguineous marriages or even an endogamic marriages within the same small community, there is a higher risk, higher chance for both partners to be carrier of the same genetic mistake because they share a lot more of DNA content from the family relationship that they have. So those couples are definitely one population that are really a good indication to have those screening to rule out those risks. The patient that do not have any knowledge of the familial background, like adopted patient, for example, could also significantly benefit from those carrier screening. Of course, if patients are coming from an ethnicity associated with a significant founder effect, like the Ashkenazi Jewish population, some specific population in Quebec as well can be concerned. We know that some population carry much more higher risk of carrying some specific genetic disease. So in this case, they could have access also to it. One of the main reasons we see patients at the clinic with this testing is actually with the context of gamete donation. So why that? I will detail that a little much later. But because all the egg and sperm donor in most of the big banks in the US, they are tested for 200, 500 genetic conditions. So if you want to purchase a gamete, like a sperm or eggs, you have to choose one, and you will have big in red saying like there is genetic flag, there is genetic flag. So most of those patients are seeking genetic counseling to help them for decide which egg or sperm donor they have to choose, what are those genetic conditions and what are the risks. Those are the indications for specific population of patients, but any couple that wants to reduce the risk of inheritance of recessive genetic condition could decide to go through an expanded carrier screening. For the gamete donation context, I already discussed it a little, and it's really difficult for the patient because most of the time when we discuss, they say that, oh, if I didn't have to go through like an egg donation or sperm donation, I would never have done like, 500 genetic testing on me and my partner, but then they feel sometimes obligated to go through the expanded carrier screening just because of the anxiety associated to the knowledge of the genetic mutation carried by the egg or the sperm donor. So for example, if they choose a sperm donor, but the sperm donor is a carrier of like, let's say like a muscular dystrophy that is quite frequent, and then the couple is like, oh, but if we don't do the testing and the kid is affected, we're going to feel guilty. So a lot of couples feel guilty to not try the best to reduce the genetic risk for their kids, for their offspring. So they may go through expanded carrier screening for this reason. But I would say that also a big proportion of the couple we met in fertility clinic, they feel that everything is already so medicalized that they want to try to stop, like to try to control things, and they not often do the genetic testing and just go with the flow and hoping that the statistics would be on the good side of it. So this is a really important things in the fertility context for genetic counseling, how to really help all the people, the patient going through egg or sperm donation, and help them like make right choices. And right choices, there is no good and bad choice, but a good choice for them to feel comfortable for pursuing like the pregnancy or conception with the donor. Now, the last part is going to be about the PGT, which is pre-implantation genetic testing. There is different type of PGT. Here is the nomenclature when we talk about PGT-A, the A for aneuploidy, so a normal number of chromosomes. When we say PGT-SR, it's for structural rearrangement, like translocation, for example. And PGT-M is for monogenic disease, so any genetic condition, autosomal, dominant, recessive, X-linked, etc., that we want to rule out. The PGT is really the same protocol for the 3 PGT. We absolutely need to do in vitro fertilization to start. And now most of the time we also do the ICSI, which is the sperm, the injection of 1 sperm in 1 egg. The biopsy, I will discuss a little about that, but it's done at day 5. And the point of all the PGT is to prioritize embryos that have the best chance to give an ongoing pregnancy, which is healthy and unaffected with a specific condition. The important to keep in mind for all the PGT, it's not 100% accurate. And in all the cases, we know that we can have discordance between the PGT result and the fetal status after all. So it's really important to keep that in mind. And the reason why I will explain it a little more, but it's because we analyze very, very few cells, and those cells are not fetal cells. And for all these cases, I will discuss also there is specific prenatal screening and diagnosis recommendation. So in vitro fertilization, I will not go in detail into it, but you know that we need to stimulate the production of ovocytes for the female and do an egg retrieval. We have some sperm ejaculate preparation, and either we can do a co-incubation, either we can do an ICSI. I would say that for PGT now, most of the PGT, we request like the ICSI being done to reduce paternal contamination. And yeah, I have a slide on that here actually for ICSI. And exactly, so the indication for ICSI, so really like to put 1 sperm in 1 egg, like the picture is not very good because there is a lot of sperm coming in, but it's just to illustrate that. So when we have a male factor infertility, we have recurrent failure, we have an unexplained infertility, or in the context of pre-implantation genetic diagnosis, that's when we're gonna use the ICSI. And there is some study, it was controversial, saying that it may be associated with some specific abnormalities like genitourinary anomaly, but we don't have a strong consensus between the studies that is able to say for sure there is a risk, but for sure it's reducing the paternal contamination. So it's something that is really largely used in all the fertility clinics in North America. In general, we hear a lot about people that are scared about the risk by itself of the in vitro fecundation, or in global, like the risk of fertility treatments. Something important to say is like one of the main risks of fertility treatment is multiple pregnancies, actually. And this is really the most important issue because of all the risks for mom and the baby, preterm birth, perinatal mortality, growth restriction, congenital anomaly, especially in the case of the mono pregnancy, and a lot of maternal contamination, complications, that can be avoided if we have like a single, reduce it, if we can have a single embryo transfer. So it's really because of that most of the clinic really try the best to transfer one embryo at the time. A lot of patients wants to transfer several embryos. They want to, increase the likelihood of being pregnant, but in specific cases, it's allowed if it's like really like a specific case, but most of the time we really try to encourage just like a single embryo transfer to avoid multiple pregnancies. And actually, some studies were saying, oh, the people going through IVF, there is higher risk of some genetic condition, but all the studies were not really able to prove that it's not associated with actually the cause of doing the IVF treatment, which is the infertility by itself. So it's really hard to know if there is a real absolute risk or if it's just because of the bias of who is doing the IVF, and it's like infertile couples. So maybe the infertility as the reason for doing the IVF, which could be associated with a high risk for genetic issue for pregnancies. Some numbers here for a specific condition associated with imprinting phenotype, like epigenetic changes. It would be maybe higher than general population for people going through IVF, but still the actual absolute risk is below 1/5,000. So it seems not to be a strong indication to offer amniocentesis to all patients going through IVF. I know it's done in certain clinics, so it really depends, but it feels that the risk is actually quite higher of losing the pregnancy because of the prenatal diagnosis technique than identifying a genetic cause. For the PGT, we need to do a biopsy. We need to collect cells. The cells that we collect are not the cells from the inner embryo mass, which is the future fetal cells, but it's cells from the external, the trophectoderm cells, and those cells are the future placenta. We cannot use the inner mass cells because there is a high risk to destroy the embryo and not being able to use it at the end. So that's why we collect cells from the outside. This is done by expert embryology team. They collect 5-7 cells from a 100-cell embryo at stage 5 days. We call it blastocyte at day 5. And once it's done, actually, they froze all the embryo and they send the cells to the PGT lab, and the PGT lab is going to do the analysis on the cells. Before, the biopsy was done on day 3, but now it's really on day 5 that we use it because there is more DNA, it's more representative, and there is a little less of mosaicism. I'm going to discuss a little more about mosaicism just after. So if we want first to talk about the PGTM, if you remember well, PGTM is for monogenic condition, and it's for people that are at risk. They know that they are at risk to pass on a specific syndrome gene condition. So for example, both couple carrier for thalassemia or sickle cell anemia, or one patient that is aware that she's carrier of X-linked condition like Fragile X, or a patient that is affected with an autosomal dominant condition like Huntington, and even also patient affected with a genetic predisposition for cancer like BRCA1 and 2. All those people could be seen in fertility clinic to discuss PGT. So the point of PGT is really to make sure that we transfer embryos that are not affected with a known genetic condition. It's most of the time combined with a PGT-A analysis, meaning that once we have the DNA and we test for that, we rather make sure there is no like trisomies or monosomies in the samples. So we have like the double selection of an embryo that do not carry an aneuploidy and do not carry the specific monogenic conditions that we want to rule out. For the PGTM, because of small content of DNA, we cannot use direct sequencing method, and most of the time we use linkage analysis, which is all way to do assumption for haplotypes status, and it's sometimes complicated for dominant de novo condition, where patient is the only one affected, we have no other relatives. So sometimes we need to use the blastocytes that we test as positive control for the test. So it's important to know that PGTM needs a lot of setup of the test before to start a cycle. It can take up to 1-2 months for the lab to design the probes, and it's really a test that is adapted to one family. It's not like a screening random test. And one risk of the PGTM is allele dropout, meaning that we can just lost the mutation in the allele. And because of that, there is a risk of discordance and a strong indication for patients that desire it to go through prenatal diagnosis if there is an ongoing pregnancy after transfer of the embryo that is supposedly not affected. So some patients, they still do the prenatal diagnosis to make sure. For some patients, if the interruption of the pregnancy is not an option, they do not do the prenatal diagnosis. Now, for the PGT-SR, as we said, it's for structural rearrangement like translocation. And for those patients that are carrier of translocation, the risk is to have no implantation, miscarriages, or a child affected with malformation and developmental delay if the unbalanced content is viable. So for those patients, depending of the size of the chromosomes, the localization, etc., it's going to be on a PGT-A platform, like is used to look at the genera aneuploidy. But sometimes if it's small parts that are at risk to be extra or missing, we can go through the PGT-M platform, the one that we just discussed with for monogenic disease, that can give more information also regarding if an embryo is unbalanced carrier versus not carrier at all of the translocation. So this is also important. And just to give you an idea, for a couple with a reciprocal translocation, we think that approximately 60% of gametes that are produced are going to be aneuploid. So if a couple is doing IVF and want to have an idea of how many embryos are going to be left, we expect approximately 40% being left from the selection of the translocation, and then the selection based on the age of the mother for the sporadic aneuploidy. So it's important for patients going through all those cycles to know that it's really like an inverse pyramid, like with really like each steps you decrease like the biological materials that you have. And we cannot guarantee for all of those patients to have transferable embryo at the end. The last one I want to discuss, I don't know if I have a few more minutes or if I'm already a little too late, so I will try to go directly to the point, but it's the PGTA. It's a super important tool that is a lot used in the North America. And as we know that aneuploidy is one of the main causes for implantation failure and miscarriages, we use this as a screening for aneuploidy to increase the likelihood of ongoing pregnancy. Here you have a very nice graph that I like to present to patients to show with the age of the mother, which is one of the main parameters for the aneuploidy, the percentage of euploid versus aneuploid embryos. And as you can see, at 36 years old, there is half-half, and then it's going down very quickly. So meaning that young patients may not benefit from the PGT at all because it may delay the process or destroy like good embryos that may have been transferred otherwise. But for all the patients after 36, it's definitely something that can help reduce the emotional roller coaster of doing transfer of embryos that are aneuploid. So it's really to reduce the time before to get a healthy pregnancy. It's increasing the implantation rate and the ongoing pregnancy rate per transfer, but it does not improve the success of the whole cumulative cycle. So those are the main indications. Increased maternal age, recurrent miscarriages, and multiple implantation failure. And I'm going to show you, because we don't have a lot of time, but the result that we can have with PGTA, depending of the labs, it's different range, but globally we have euploid, mosaic, aneuploid, and no result embryos. No results are not presented here. No result is when the test didn't work. When the test didn't work, we just use the statistical risk associated with the maternal age. For those results, the euploid are the ones that we want to transfer, the higher chance for success. The aneuploid are the ones we do not want to transfer because there is not a lot of chance that it's going to work, higher risk of miscarriages and abnormal pregnancies. And the one I want very quickly to talk about it, and I can answer question after if you have more questions, is the mosaic embryo. As you imagine, when we do your biopsy on 5 cells on the external layers, we may have a different content between what we have in the biopsy and when we have in the fetus at the end. There is a lot of paper in the last 2-3 years talking about different priority of mosaic embryo transfer. The only thing I will show you is like this study that now there is more than 1,000. It was increased like since 2021, where they say that depending of the type of anomaly we see in the mosaic biopsy, there is priority that can be determined. So now there is a consensus that the segmental mosaic, so not just a piece of chromosome missing versus a whole chromosome missing or being extra, the segmental one should be prioritized. And they also said that depending the percentage of the cells we have, low mosaic versus high mosaic, the low mosaic, so the less proportion of abnormal cells should be chosen, like if we have the choice between 2 mosaic embryos. For the mosaic embryo transfer, sorry, it's something that now most of the clinic allow, but you need genetic counseling because it's decreasing the likelihood of an ongoing pregnancy. We talk about maybe 50% of ongoing pregnancy for low mosaic and 30% for high mosaic. And it's increasing the risk of having a kid affected with the mosaicism in the fetal DNA. Sorry. So this is going to be my last slide. I could talk about mosaic embryo transfer much more, but I think it's a very specific subject, so I can answer questions if you have more after. But globally, it's important to know that when patients did IVF cycle and PGTA, and they have an haploid embryo transfer, so an embryo that is not supposed to have any aneuploidy, they do not, it's not recommended for them to do like a serum screening, like biochemical test, because the detection rate is lower than the PGTA. It's possible for them to go through the non-invasive prenatal testing, like those testing are similar to PGTA, so it's not an obligation, but they can do it. And of course, for all of those patients, it's super important to still do the nuchal transleniency ultrasound and the morphological one. I'm sorry. And last one, for the mosaic transfer, when we transfer those embryo, it's important to know that so far the recommendation for prenatal diagnosis is still on. So the patient that transfer mosaic embryo should still have amniocentesis, not chorionic biopsy, because chorionic biopsy is also looking at placental cells and we want fetal cells. But I would say that more and more patients, because the embryo are so precious, they are not going through this option, but it's why the genetic counseling is so important for mosaic embryo transfer. So this is the end of the talk. I'm sorry if I went a little more than the time that I had. So I will stop sharing my screen and I will be available for questions.
Great, excellent. Thank you so much, Claire. That was wonderful. I learned so much today from you. I feel like I was back in genetic counseling school and trying to absorb it all. I'm sure I missed some really key points, so I'm glad that we're recording it so I can go back and review those. I'm happy to take any questions from the audience. Please feel free to write them in the chat box and then I'll read them out to Claire. But while we wait for other folks to ask some questions, I just had some curiosity of my own. And so I was thinking about all the difficulty that obviously goes into the whole IVF process, prep for it, the extraction, and then the embryo planting and all of those things. What are your thoughts on the upcoming cell-free DNA technology in terms of identifying especially monogenic diseases? Because we know NIPT can be very good for trisomies. If something happens, you know, you could not delay the process of implanting the embryo. So I guess my question is two-part. First part is about those individuals that are of advanced maternal age and they want to have their embryo transplanted and do the NIPT afterwards as opposed to doing PGTA. Question number one. Question number two is in terms of the NIPT use for monogenic disorders. So for example, knowing whether or not the baby is carrier or affected. So
Exactly. So it's interesting question. For the first part, for the advanced maternal age, I would say that if a woman does not need to go through IVF, she would not do PGTA, she would just do natural conception. If she can achieve natural conception and not having miscarriages, she would definitely go for the NIPT options. Like it's much more simple, if I can say so, to go this way. I would say that it's, if the couple is up to do an IVF anyway, because it does not work naturally, then for them, it's like, oh, it's just an extra option that we had to select the embryo and avoid. It's really to avoid this, like, you know, up and down for them. It's really a personal decision. It depends on all the journey they had with infertility. But for some couple that had recurrent failure, you know, like failure of insemination, like 9 insemination failure, 3 miscarriages. And when they hear that there is a way to reduce the implantation failure and the miscarriage, for them, it feels that much more efficient than waiting for maybe a pregnancy coming in. So it's really different depending of the reason why they go for it. But I would say for some patients, it's really a relief to know that they will reduce the likelihood of a failure. We know that even with a good embryo tested with PGTA, it's only 70% of ongoing pregnancy, but it's still much higher than without PGTA. So I would say it really depends of why they are at this point looking for the PGTA, and most of the time it's because they need IVF to have pregnancy anyway. And for the second part, actually, from my knowledge, I'm not a specialist for this part, but the non-invasive, like NIPT for monogenic condition is not yet usable in clinical setting. I know there is a lot of research on that, but in my general practice, since I'm working in prenatal, I never heard about like a clinical utilization of it. I think there is some challenges depending where the mutation is coming from for paternal mutation versus maternal mutation. So I think some mutation are able to be detected, but it's only research based so far. So unfortunately, those couple known carrier for those mutations, the only option they have is to go through a prenatal diagnosis or a pre-implantation genetic testing. And this also, I don't know in Pakistan, maybe you can tell me, but depending the view on medical interruption of pregnancy, it could be also really helpful for those patients to do the PGT instead of the amniocentesis to avoid having to terminate the pregnancy.
No, exactly. No, those are excellent points. We again, for sake of time, I'll say a couple more things. So Myla, who is also a co-director, also has a question for you, and she's first compliments you on an excellent presentation. And then she's saying she's curious about whether there are certain genetic disorders for which IVF is not an option, as in where's the line drawn regarding severity of the condition, and if there is even any line at all.
It's a very, very relevant question, a very good ethical question as well. So I think it's important to discuss about that. Actually, right now, I can say that in Canada and I think in the US, it's the same. We authorize PGT even for adult onset predisposition for cancer, like BRCA1, BRCA2, Lynch syndrome. So it's something that now is accepted. I would say that the line is drawn with like penetrance sometimes. We had, for example, requests for a multifactorial disorder, like we had requests like for autism. They want like to do sex selection of, you know, choosing a female embryo to reduce risk of autism. Those things we cannot really say that we're comfortable, but we can make it multifactorial and we cannot, you know, guarantee reduction of the risk really. So we accept all genetic conditions that for sure are severe, all the autosomal recessive condition, everything that is doable technically also, because there is some limitation. And I know during all my practice, the last 5 years, it happened once that a specific mutation for a patient for a specific condition was not technically doable by the lab, but most of the time the lab is able to do it. So for the adult onset condition, something to keep in mind is we allow to do the PGT. So for example, BRCA1 mutation. But then what about the recommendation to do prenatal screening for it after, once the pregnancy is on? Because it's something very questionable to do an amniocentesis at 15 weeks on a fetus. If the fetus is a female fetus and is carrier of BRCA1 mutation, what about taking a decision to do a medical termination of pregnancy? I'm not even sure that the medical team would be agreeable to do that. It's very, very complex because the penetrance is not 100%. This fetus may have a perfect healthy life. So all of that is questions that are really important for all the medical team to discuss. So it's not a big guidelines, but it's more like discussion within all medical teams. And we talk a lot, us like the genetic counseling group with the doctors, the lab, to see what can be done. But there is not like a clean line drawn like for those conditions.
Yeah, what it sounds to me is that a lot of these discussions at some point would require a much more robust scientific discourse, whether it's with the religious community of the country and the culture and the, you know, the maybe the political leaders and the scientific community all need to come together to have consensus amongst you know, what is allowed and what
acceptable,
is allowed in certain cases. So you're bringing some really excellent points to us to discuss, and I'll take this as a segue and bring in Dr. John Weil into this discussion. So Dr. Weil is one of our great supporters, especially in terms of the international genetics community and psychosocial genetic counseling work that is so important. And so what I wanted to do is just to bring him into this dialogue. He's bringing up a really excellent book that I haven't yet had a chance to read. It's by Holly Singh. It was recently published in 2023, and it's called Infertility in a Crowded Country, Hiding Reproduction in India. It's published by the Indiana University Press. It sounds to me like a book that I would really love to read. And Dr. Weil, if you'd like to unmute yourself and give us your perspectives if you've had a chance to read it or if you have more to say on the topic.
Okay, thank you. Yes, I have read it, and I'm going to switch over to, in order to be efficient, I'm going to switch over to what I've written about it. The author is a professor at the University of South Florida. As her full name, Holly Donahue Singh, indicates, she's American. She always had an interest in India, and her last name indicates that while she was doing her research there, she met the man to whom she is now married, an Indian. The book's based on ethnographic research she conducted for her PhD dissertation from 2004 to 2007 in Lucknow, India. It has a great deal of valuable information concerning the complex emotional, familial, social, and power relations that are responses to infertility in North India. The extensive scholarship includes articles and books involving research in Pakistan. I've recently finished reading it, and I've arranged to have a Zoom meeting with the author now that I have read it. Before I say anything more, I want to say, Claire, that was an outstanding presentation. I had to focus every instant, but when I did, the clarity with which you presented things was beautiful. Thank you.
Thanks a lot.
Yes, for sure. But this is a very interesting book. And clearly is pertinent to the immense, interlocking aspects of infertility in Pakistan. The majority of, the individuals that the author interviewed, both patients and clinicians and other people, were predominantly Muslim by intention. And it is, I mean, I just learned a tremendous amount about the depth, not only cognitive and intellectual, but heartfelt, heart-rending, deeply ethnocultural aspects of infertility in North India and also.
Thanks so much, John, for enlightening us. We're always so glad to have you, and your insights and your constant support is just so meaningful to us. And I know that I will be downloading that book on my handle immediate. Because again, when we live and breathe in a society, we forget to really look at it from an outsider's perspective or from a perspective that isn't uniquely ours. And so just to see what she has to say based on, of course, the research that she's done would be really helpful.
For personal and historic reasons, I, for years, have been on a listserv for radical feminist research. And occasionally, I mean, there's frequently things that are of interest, but occasionally there's something of, direct interest and importance to my work. And this time, as in the past, when I ordered the book, I also communicated through the listserv with the author, and I now am going to have the opportunity to speak to her.
How timely for us that you had this.
How timely for
How
me.
timely. With that being said, I'd like to now invite Dr. Rizwan Malik to the floor. If he could please unmute himself and turn on the camera, that would be terrific. Again, like we mentioned earlier, Dr. Rizwan Malik is our resident expert in the Pakistani IVF field and what are all the amazing things that him and his colleagues are doing in Pakistan. With that being said, Dr. Malik, the floor is yours. If you can please enlighten us with some of your experiences in Pakistan. What are some of the major things that you see in your clinic in terms of reasons for infertility, and then of course enlighten us in regards to your counseling techniques and some of the ways that you talk to these patients that come to you. Thank you.
Great, thank you so much, and what a wonderful presentation. I think about some of the causes of infertility. But one of the things that we face in a developing country is the cost. I think what you brought up is that when we start talking about different mutations and checking for them, AZF mutations to PGTM, doing those cases, when you start doing those, with our currency depreciating by 100% inflation within the last year, I think affordability becomes a major issue. And with the organization, I think behind it, advocating for affordable care in Pakistan for genetics is important. The couple things I did want to mention, cystic fibrosis, I'm surprised to see, especially in the Peshawar part of Pakistan, and I've seen a number of patients with cystic fibrosis. So that's important to keep in mind. Thalassemia is quite a bit we see. And, important to keep these genetic causes in both infertility and recurrent pregnancy loss patients. The other thing, I think, just to add to the whole topic of what has been presented, quite a bit that we are learning in reproductive endo and infertility field right now is epigenetic control of gene expression through DNA methylation. It is driven by lifestyle, diet, smoking, exposure to toxins, and in utero exposure to various stimuli, such as a high level of sugars, glucose, exercise, stress. So all those things. So what a lot of it is reversible and irreversible genetic causes and what's going on in our body. So we may have genetic predisposition, right? We talk about those multifactorial things. And then they are affected by DNA methylation, by our lifestyle, our diet. And that's really, I think, where we can make an impact. In North America, we're focusing, but I think even in Pakistan, we can make a impact by advocating healthier lifestyles, cutting down smoking, exercise, and better care during pregnancy for the mothers, as they're affecting the next generation of how they care during their pregnancy. So that, I think, is important. That's a lot of it is being addressed here in the United States and coming through as to how these epigenetic changes causing the effects during the lifestyle, and how lifestyle modifications can reverse those changes in aging and some of the causes like PCOS effects and other causes that may cause infertility. So those are great and great presentation. Thank you.
So if you don't mind, Dr. Malik, I'd like you to stay on for just a little bit. So walk us through a typical session that you might have with somebody in Pakistan when you are, what are some of the questions that come to you? What are your common responses that you give, just so that folks online can hear from you and learn a little bit more from you? What language are you using?
Right. So I think we get a wide variety of patients, anywhere from extremely educated software engineers, physicians that are very well educated and they know the research, so they understand the depth of the field and understand, to somebody who is really very education may not be educated at all. So wide variety of patients. I think that's where, as you train the genetic counselors, is really to be able to address the needs of a wide variety of, I think, the understanding and education in there. And I think and that's what I found a bit different. When I was going from US, I practiced here for well over 30 years, and I started in Pakistan. I was thinking, how will it's a different country, what will I do? And all that. And what I found, it was no different than US. Really, people, their expectations are the same. Their suffering is the same from genetic diseases. No different than what I face in my practice in US. So I think I've minimized that gap to a point. I do some sort of a little bit of prioritization, if you will, of testing. So instead of US, I may order 10 tests altogether. Over in Pakistan, I may do the most common, the first, second tier testing. So that may be one thing. And the other thing that I feel, one of the things that I faced myself during this process is really where people come in for inheritable diseases and during early pregnancy for testing, and then they really cannot, it's just access is not there. By the time you get it done, they're 20, 23 weeks. And then at that point, termination is really quite, I feel, not an option. And I think that's where we need to emphasize genetics, what's out there. One of the things, I kind of feel a bit that sometimes termination is considered more normal, if you will. When I talk to OB-GYNs, they talk about over there termination as not as big of a deal. Even in Texas, we sit here and talk to OB-GYN here, and they're, oh my God, it's like termination, and there's so much discussion and such a big barrier. And sometimes in Pakistan, even though it's a Muslim country, which I was surprised myself when I started practicing, my expectation was that there would be very little or none. Surprised to see quite a bit, even sometimes for gender selection and other terminations are happening on a basis. So I think that's where education, involvement of our society, involvement of our academics, and really the educated community to go out there and introduce these technologies, education and empowerment of women, and education of women will make a difference in bringing down equality and opportunities for women, and some of the genetic things that may be there.
So what I'm hearing you say, Dr. Malik, is our shared humanity is what connects us all. Our emotions and our thought processes could be all very well connected, whether you're talking about a patient that you see in Texas or in rural Pakistan. The innate human want, and in some cases need, to have biological children could be very well connected wherever you go in the globe, right? And the lack of that very human nature and spreading the seed or the progeny not lack of progeny could be very psychosocially devastating, whether you're talking about somebody in San Francisco, California, or Balochistan, Quetta, Balochistan, right? And so for that, I thank you. But what you're also pointing out, which is very keen to me, and what I'm taking away from, is the lack of access to healthcare. And when we talk about that lack of access of healthcare, it could mean so many things. It could mean education. It could mean lack of facility. It could mean, so many different things. So our jobs here is to propagate that message, is to talk more and more about it and do the best that we can. And so I thank you for all your services that you provide. And I know that, many patients walk away from being treated by you with hope and welfare for themselves and their families. The last thing I wanted to ask you was about a little bit psychosocial, and if it is too much to deal with in this small session, please, by all means, we can pack it for another day or time. But do you find it in your practice that there is a harsher burden on women when there is infertility in a couple in Pakistan versus when you see it elsewhere? Or do you find it very similar, it's the same, not too much difference?
No, I think both, not just women. I think both ends. I see there is a bit more compulsion to have. There's such a, I think the concept of family, a couple gets married in the US as well. I see patients here 6 months, they're walking in, my God, we want a kid. And the burden is here as well. And people separate or they go different directions when they're faced with untreatable infertility. In Pakistan, I think there is quite a bit of pressure on women as well as men, for that matter. So that's where I'm seeing. So men with like azoospermia, very low counts. So that's where marriages are breaking up more now than before. And so I think that's where one has to be able to support those couples with recurrent pregnancy loss, with infertility that's related to genetics. This is not something they were born with, not a choice, not something they could control. And especially all these the different conditions we've talked about. I had a patient from UK at age 22 with premature ovarian failure. So that's purely genetic at that point. And really she's struggling with not being able to get married, or kind of looking at a different kind of a situation, which I think not as much in the West. Here it may be, okay, fine, here I'll expose kind of, or being open to your partner and being able to bring that into a relationship and find a partner that would be accepting. And maybe not as much in a country in Pakistan as such. So there is quite a bit of burden. But what I found was that the pain and suffering is about the same. As I see a couple from Texas who's coming in, they just are longing for a child, to a couple from Balochistan who's coming in and can't see. One thing that's been interesting actually is how easy and quicker is adoptions rather than family. Frequently couples coming in, my brother's son I adopted, my sister's son. So very kind of, I think those are a bit different I see in Pakistan and there. And but what I was surprised with is cross-country adoptions. Like Canada does not allow adoption from Pakistan, which I was shocked with as many Canadians as how many Pakistanis in Canada that are living that are infertile, and Canada law does not allow any adoptions. So, and in our country, we are aborting children, and abortions are happening on a regular basis. So that's one of our initiatives, is really to be able to look into that and decrease that burden, decrease the genetic burden, in terms of genetic diseases, and a lot of can be through pre-conception testing, like you talk about these panels. But unfortunately, when you start talking about the panels at a cost of $250, $300, it doesn't seem like a whole lot of money in US or Canada. But when you convert that $300 into Pakistani rupees at 300 rupees to $1, that's a person's salary for a whole month or sometimes 2 months. So a month's salary, giving that up to a test, most of the people and that's also discounted rates in the United States. When you look at when we actually convert that into European kind of to actual cost in Pakistan, $600 to $700 for testing that. Now you're talking about very few people who can really afford to do preconception testing and screening for genetics.
Yeah. Well, I'm so glad that we have some genetic counseling students on the line with us at the moment that are hearing you talk. It's quite important for so many reasons. And of course, the one thing that you said that, of course, hit the chords with me is the fact that, you have to normalize these things, especially when you can identify the cause for the lack of fertility. And then you can make them understand that their thoughts and their feelings and their emotions are all valid, because this is obviously removing or taking things away from them that they don't have control over. And so the education bit and the normalizing bit goes hand in hand. You can say what you're feeling is obviously it's very valid. And here are the reasons why we believe in science, why things are happening the way that they are, and how random it all is. And then, of course, Pakistan being a religious, that those to rely on as well, that we could say, there are Maulvi Saabs and other imams that can help with the psychosocial aspect of counseling as well. And so as a team, we can move forward, and as a team, we can make things better a little bit at a time for all of our patients. So on that note, I was going to see if there are any more questions or comments.
On the along those lines, I think important to emphasize the epigenetic changes, and really they are happening with lifestyle and diet. So in Pakistan, that's something that really I think would be one of the topics for the future, as to one can consider as to how kind of more research is showing that our lifestyle, our end user exposure can modify, can affect epigenetic effects. And same genetic makeup, one sister can show up with really bad pieces and fertility, other sister may not. So that's where I think we can change our lives or change our outcomes for our patients by advocating healthier lifestyles.
Absolutely. It sounds like that would be the low-hanging fruit, right? Like, let's eat a little bit healthy. Let's exercise a little bit more. Let's make sure, that you're preventing STDs and things like that, basic things that we can all chip in a little bit. That sounds wonderful. So I am seeing one more question for you, Dr. Malik, in the chat box. And this is from Mr. Ali. Let me make sure I have that correct. Yes, Ali Reza is asking, is there any institute that offers IVF courses or diplomas in Pakistan?
IVF courses, diplomas in Pakistan, at this stage, I'm not. There is Quebec University does have a reproductive physiology PhD. So that is available, certainly, if somebody is interested. Quebec University offers, and I think through our society, we are offering genetic courses. The Pakistan Genetic Society is offering genetic, that you mentioned, genetic counseling programs. So those are, I think, pretty pertinent continued educational opportunities.
Okay, so Mr. Ali Raza, if you're interested, you could probably search for those. We don't have a member of that team here to explore more, but that's news to me as well. I'll definitely look into that as well for myself. With that, I want to thank Claire, so much for an excellent presentation. And I want to thank Dr. Weil and also Dr. Razan Malik for his precious time and for educating us and for helping all the patients in Pakistan. Thank you so much. And with that, we'll conclude the webinar.
Thank you for the invite. Have a good day.
Thank you. Great presentation.
Thank you.